Hello.
Ready to get started?
Yes, I think we should.
Okay, great. We'll get started just to be mindful of time. My name is Erin Bryce. I'm the Administrative Director of the Integrative Medicine Collaborative at UCLA Health. We formed about 2 years ago. Now we've got around 35 programs in the collaborative that are all non-pharmacological and evidence-based. And we are all aimed at empowering patients in the community with tools and resources to proactively manage their well-being. We are hosting a series of monthly webinars leading up to our inaugural conference, which is scheduled for May. And today we are lucky enough to have Dr. Rashmi Mullur. Dr. Mullur is going to be speaking about telehealth in integrative medicine. And Dr. Mullur is the Chief of Telehealth at the VA, Greater Los Angeles, and has also led the VA in the telehealth implementation throughout the pandemic. Dr. Mullur has been an endocrinologist with UCLA for 3 years, as well as our integrative medicines lead for the educational pillar. So welcome. Thank you for being here, Dr. Mullur, and I'll hand it over to you.
All right, thank you for that introduction, and hello everyone who's joined. I am happy to talk to you today about telehealth and integrative medicine. It's a topic that is of incredible interest to me. I took on the role of Chief of Telehealth at the VA Greater Los Angeles in May 2019, and at that point, telemedicine was more of a innovation and way to incorporate digital tools into chronic disease management, and actually has a lot of parallels with integrative medicine. I don't know that we could have anticipated, or any of us could have anticipated, the amount by which we needed to scale telemedicine with the pandemic. But certainly I'd like to kind of share what we've learned through the VA system here, and also talk about parallels and what we can learn as we try to implement telemedicine throughout other health systems like UCLA. I have no financial disclosures to report. To go over some of the objectives of this talk. So I want everyone to kind of appreciate the landscape of complementary and integrative health prior to COVID. This audience is very savvy and kind of understands the benefits of complementary and integrative health, but I'd like to kind of review those and talk about those, especially as we come to where we are today in 2020 and kind of our needs, our patient needs and our provider needs. Also, to recognize the benefits and challenges of telemedicine implementation. I would love to tell you that it was just an easy sort of, transition from face-to-face visits to virtual care visits, but as I'm sure all of you can appreciate, that has been a challenge. So talking about kind of what works and what doesn't work and how that impacts complementary and integrative health. I also want to review the VA
Dr.
model.
Mullur, sorry to interrupt. Your voice is kind of going in and out, as I think it's your headset. I don't know if you can take it off or maybe just keep it steady.
Let me try this. How's this?
It's good. Yeah.
Okay. All right.
Yeah, that's good. Thanks.
Also, I want to review the model of VA telehealth and teleintegrative medicine and talk about how the landscape at the VA allowed this transition to teleintegrative medicine and talk about the unique factors there. And then finally, to just kind of understand the prior evidence, the current evidence, and kind of the future state of complementary and integrative health delivery via telehealth. So with that, let's talk briefly about just kind of pre-COVID, right? So pre-COVID, the benefits of integrative medicine are actually well established. And I often, still find both patients and providers ask me about, well, do we know that integrative health works or integrative medicine works? And the truth is we do, right? It's evidence-based. The NCCIH, which is a subset of the NIH, has had a large operating budget to investigate these complementary and integrative health therapies, and has shown that for many services that translate well into the virtual care space: mindfulness, yoga, Tai Chi, hypnosis, guided imagery, etc. That these modalities are not only effective, but can also improve chronic disease management. And that's really where we see things. And because we are able to improve chronic disease management with integrative health, we have programs like the Ornish Lifestyle Medicine and Cardiac Rehabilitation Program that are reimbursable and actually improve disease morbidity and mortality for patients suffering with chronic disease, and can be cost effective. And then finally, we know that integrative health treats chronic pain and stress in a challenging population, right? So what I've shown here in this last slide is the VA kind of wheel of health, and this is the guiding model that the VA has used to really integrate the whole person and whole health based approach to care. And so it's really about moving the body, understanding patient's environment, both physical and emotionally, personal development for the patient, understanding nutrition, understanding their spiritual connection, and their mind, really. And so these are the core principles of integrative medicine, and we know that those are effective. So the question then becomes, how do we translate this to the virtual space? So before we talk about that, we kind of have to define what telemedicine is. So telemedicine is the use of medical information exchanged from one site to another via electronic communications to improve a patient's clinical health status. And there are different modalities of telemedicine delivery. So there's asynchronous telemedicine delivery. So that's the use of technology to securely acquire information that then is then interpreted by a provider at a different time for clinical evaluation. And this can also be implemented with patients asynchronously. So for example, this could be something like a patient who has a new rash that gets an image of that taken via a iPhone and then sent to the provider for interpretation. Or this could be the delivery of a meditation program through an app where the patient is participating not in a live program, but through a pre-recorded session. So asynchronous delivery has some benefits and challenges, and really in the integrative space really has a lot to do with kind of patient engagement and kind of figuring out whether or not the patients are participating. Synchronous telemedicine is more of the real-time video conferencing. So this is kind of that kind of virtual visit using either a smartphone, tablet, or computer. And this also is dependent on patients' kind of telehealth literacy, and in terms of the integrative medicine, really is the primary way we're trying to deliver a lot of these kind of integrative health modalities. And then remote monitoring, which I'll touch on briefly, that's the use of technology to monitor patients' symptoms outside of conventional clinical settings. And this could also be kind of health parameters. So this could be something as simple as a patient, checking in and filling out what their blood sugars might have been, or this could be as advanced as wearing a wearable device. And when it comes to integrative medicine, I think this is where the innovation in tele-integrative medicine really is going, and I'm excited to see kind of what develops there. Other definitions you might see in the literature: mHealth refers to mobile health applications. So this is really apps on phones, tablets, computers. eHealth is kind of what we're already doing now. So this is health practices supported by electronic communications. So that includes email, patient and provider portals, as well as secure text messaging. And then telehealth is a larger term that kind of encompasses not only kind of medical care that's provided, but also health education, training, and other ancillary care services. So when we're talking about integrative health delivered via telemedicine, we're really talking about telehealth, okay? So what are the benefits and challenges to telemedicine delivery? So benefits, I think it's fairly simple to say that access is improved if we're able to access patients virtually. I think the challenge here is that both access and cost are both a benefit and a challenge. So I'll talk about those two separately. But specifically, we know that we can increase mental health access, and that's been a huge boon to the VA, and we've seen that over the years. It's also helped us provide care to our rural population, so patients that are outside of the city center, patients who have difficulty accessing the medical center due to disability or trouble with travel. It decreases the burden of travel. Obviously, in the COVID era, this allows for social distancing and is, incredibly beneficial. Patients are really satisfied with telemedicine delivery, right? They really love the idea of not having to, get in the car and get to the clinic. The challenge, however, remains, uh, regarding how we get patients ready for and prepared for those visits. And then cost. Telemedicine actually is associated with cost savings. So it's associated with cost savings in a number of disease processes. It can decrease hospitalizations and morbidity when it comes to chronic diseases like heart failure. It can improve screening and eye care in patients with diabetes. So there's a significant benefit there. But then when we transition and talk about challenges, again, we see these same things kind of come up: access and cost. And the challenges with access when it comes to telemedicine, it mainly has to do with devices and internet access. So we know that our most vulnerable populations have access challenges, and this is related to internet and broadband devices and just kind of telehealth literacy. So there's an education component that's really required there to really help patients kind of reach that hurdle. And then televisit experience, right? So whether a patient feels comfortable sharing their health concerns via telemedicine, and whether the provider feels comfortable, establishing that rapport that's needed. And that over time, I think, will develop, but that remains a challenge right now. And then cost. There's an upfront cost with telemedicine delivery, right? So most health systems or health clinics really have to kind of take into account that cost, and that cost isn't just providing devices or training and education. It's really about devising new clinical workflows and preparing the patients for this. So there's a staff that needs to be dedicated to preparing patients for their telemedicine visits so we can actually see those benefits and access. I want to just share some data from UCSF, and this was their primary care experience in 2020. And what this shows is their data on 2 weeks prior to kind of the COVID lockdown here in California and 2 weeks after. And what they're showing is the percentage of patients receiving telemedicine and the demographics of those percentages. Now, what's important to note is that these differences are actually much more pronounced because the percentage of their telemedicine visits scaled up from 3% of their average visits to 80%. So despite the rapid scaling of their telemedicine, you can see that after the telemedicine implementation, you actually saw decreases in certain populations' access. So patients who are Black, Latinx, Asian, patients who were older, patients whose primary language was not English, our Medicare and Medicaid patients actually saw a decrease in the percentage of patients utilizing telemedicine. So the concern there is that this rapid scaling can really increase healthcare disparity. And that's our primary concern when we're trying to make sure that we implement telemedicine. We want to make sure that we're not worsening healthcare disparities. When it comes to integrative medicine, how can we deliver integrative medicine via telemedicine? And I think one of the key points is that we have to remember that this is more than just wellness, right? So what we're providing in integrative medicine is more than just a yoga class drop in, etc. What we're really trying to do is return care to the home, right? So we're really trying to find different ways to provide that patient-centered and whole person-centered care. And so we have unique challenges, right? So I think the biggest one remains cost and reimbursement. Within the VA population, certainly we are a health system that, we cover our patients as an insurer. So we have a different protocol and plan. But in the private world and in other health systems, cost and reimbursement remains a challenge. So post-COVID, certainly the parity for pay between phone visits and virtual visits became equal when it came to physician and nurse practitioner care and kind of provider level care. But when it comes to ancillary services, there still remains a gap in terms of what can actually be covered. So that remains a challenge for some of our patients, because when we're talking about delivery of integrative health modalities, mindfulness, yoga, acupressure, etc., the cost the cost and reimbursement really has to fall to the patient, because there aren't methods for us to collect payment for those types of services. There's also the issue of patient engagement, right? So when you have telehealth delivery of integrative medicine, you really have to take time to develop that healing space virtually. And, um, you know, we've had some experience doing that at the VA. We've had a long time, but I think when it comes to developing new programs, it's really about setting that expectation and getting the patients to really understand that, this is part of care, not just kind of a wellness class that we're saying it'd be great for you to do. Um, the other thing that's important to note is patients and providers developing that connection and empathy that is so integral to integrative care, right? So when we're treating the whole person, we are connected with our patients, and finding that connection virtually can sometimes be a challenge, but I think it's something that can be overcome. So I want to take a little aside here and tell a little story about the VA and how we got here. So the VA established telehealth use in the early 2000s, and this is a slide. It's actually based on 2019 data, and the reason I show this is because it's important to note that we had tons of telehealth delivery even prior to COVID. So we had more than 900,000 veterans receive telehealth services via the VA. A third of them lived in a rural region, and this is really the primary impetus for the VA to have invested in telehealth. And the VA telehealth expansion really began in the 2000s. And prior to the COVID pandemic, I was charged with making sure that we had our at least 45% of our primary care and mental health providers up to speed on telehealth delivery. So when it came to time for COVID and scaling, we were already ahead of the game. And the reason for this is not only rurality, we also have a multi-morbid kind of disease population, right? So our veterans suffer not only from mental health conditions related to their service, many of them suffer from chronic pain, and the combination of a mental health disorder as well as chronic pain often increases the risk of kind of chronic medical disease. And so at the same time the VA was expanding the use of telehealth, they were also investing in complementary and integrative health. And, this kind of confluence is really what has been kind of innovative at the VA, as well as also kind of inspiring for what we've been able to accomplish. So our veterans come back and from their service, and many of them are suffering from a wide variety of symptoms: back pain, headaches, constipation, sleep disorders, PTSD, depression, anxiety, and treatment of these kinds of uh, kind of complex symptoms is really challenging with traditional medicine. And we know that integrative health can really improve those symptoms. So the VA made a concerted effort to try and push these forward. And what's really great is that in 2018, actually before all of this, the VA's kind of action items for kind of integrative health included the development and delivery of integrative health via telehealth. And so that's really been where we have been able to show the benefits of these services. So this is data from the VA's kind of early experience scaling telemedicine. So you can see once video visits kind of really started in earnest in March, kind of when the early lockdowns took place, the VA really scaled primarily in mental health. And you can obviously see why that would be an easy transition. But also in specialty care. And specialty care is really where complementary and integrative health is kind of classified in the VA. And so you can see that those visits only increased over time. I want to take a minute to show just a little bit of the data on the distribution of kind of the Greater Los Angeles virtual care and integrative medicine distribution. So we have been providing integrative care throughout the VA through telemedicine. And what we were able to show is that, we don't have as huge a disparity as we thought we would. So our percentage of patients that are accessing complementary integrative health virtually, we have more than half of our population is greater than 65, right? Actually, yeah, more. I mean, some of them are 8% of them are over 85. And so that's really heartening, because when you look outside of the VA system, certainly there's an age disparity. And I think the primary reason we've been able to get this level of engagement and access in the elderly population has to do with our ability to provide not only devices for digital access. So the VA has a program to provide tablets for digital access, but it also has the ability to provide patient education. So I have a team of technicians who can really walk a patient through a virtual care visit. And we know that if a patient is walked through how to connect, how to sign on, they are more likely to complete their visit. And so I think that not only applies in primary care and in mental health, I think it definitely applies in complementary and integrative health. And then when we want to talk about, kind of racial differences in telemedicine access, you can see that we mirror kind of the distribution of our VA population. So there's not some great disparity kind of between the number of veterans accessing complementary and integrative health. So let's talk kind of deeper into kind of how we translate integrative medicine into the virtual care space. So there are some modalities that are pretty well established in terms of delivery into the into the virtual care space. So those are things like mindfulness and mind-body movement modalities, right? And so I'll kind of review the data on that and kind of show what we've been able to do at the VA. And there's emerging evidence in terms of acupressure and hypnosis, and I'll talk about those a little bit. And then we can talk about kind of the future state, kind of where we're going in terms of remote monitoring, digital health tools, and kind of integration into clinical care. So mindfulness and telehealth. This really doesn't need to be said, but there are a million mobile applications and online courses that are widely available on mindfulness meditation. I think it's hard to name something that's not promoting mindfulness right now. I think the primary challenge is engagement, especially with asynchronous use. So as a physician, if I'm going to recommend someone participate in mindfulness, I want to be able to offer them a resource that they're going to be able to engage with and understand that there is a bi-directional sort of engagement. So not only am I going to be invested in how many visits they participate in and their actual experience, but the patient is also expressing that or expecting that as well. I think when we have asynchronous use where we tell patients to kind of go off and use an app, it's very hit or miss. We have some patients who will use it right away and will be early adopters, and that's great. But you have a significant amount of drop off there. We know that this remains mindfulness remains an effective treatment for pain, depression, and stress for both patients and caregivers. It's pretty easily delivered via telehealth. Data actually from Korea during the COVID-19 pandemic actually showed that these mindfulness practices were feasible and effective in improving the mental health and wellness for both patients and caregivers. I think we all know this. I want to just highlight here, you know, the UCLA MARC has both live classes as well as asynchronous pre-recorded classes. And what's great here again is that this is that level of engagement that you want, where it's not just an app where a patient's kind of scrolling and trying to find a mindfulness meditation that they can do in 2 minutes in between visits. I think those programs are useful and great, but when we're really trying to cultivate mindfulness into clinical care, using these sorts of classes are really important for the patient to really understand that clinical integration. So the link is there for anyone who's interested, but we have both live online classes as well as pre-recorded online classes for patients here at UCLA. The other modality that's really popular, obviously, to deliver via telehealth are yoga and Tai Chi. So both of these mind-body movement modalities can be easily incorporated into telehealth. We know this not only based on applications that are promoting kind of these mind-body movement modalities, but also like online classes, etc. And these classes can be delivered synchronously or asynchronously. Again, that question of patient engagement comes in. Also, the challenge there is whether we're talking about therapy or wellness. So we know for a fact that yoga and Tai Chi are used by patients throughout the country and throughout the world actually as a wellness-based practice. But when we're talking about integrative health modalities for clinical care, we're really talking about yoga therapy. And when we talk about that, what we're really trying to show is that these programs actually improve clinical symptoms and improve and are actually efficacious in chronic disease management. So a study comparing in-person yoga classes versus telehealth yoga classes revealed similar improvements in back pain, anxiety, and depression. And the participants were equally satisfied with either method of delivery. But again, when we're talking about engagement there, we're really talking about the synchronous delivery. So for a patient who's you're recommending yoga to, you really want them to understand that you don't want them to just kind of sign up for an online class. You want them to be involved in a program where they're going to engage in practices that are going to improve their symptoms long term. And what's nice is that, delivering yoga and Tai Chi in the virtual space, both patients and caregivers can participate and benefit from these modalities. This is the data we have here from the VA, just from post-COVID, kind of April through October. And, in blue is our yoga encounters, and in orange are our Tai Chi group encounters. And you can see we're able to kind of see, scale up, and at some point we're able to see as high as 325 patients via these virtual programs. And what's nice here is that the benefits is that there are fewer missed visits, and these can be delivered at the home or kind of in the clinic. So we have two modalities by which patients can access these virtual programs, and we have a centrally based teacher that's at our main campus, and one therapist can then reach a larger audience. What's nice is that when you have these kind of group-based classes that patients are kind of signed up for and registered for, you really get that camaraderie of a group visit. Obviously, there's cost savings in terms of travel, and at the VA, co-pays. Certainly, outside of the VA, that's a challenge. There are some challenges with yoga delivery, right? So There's always the risk of fall. Yoga is not a, blind kind of uh, intervention that you can just deliver without any concern. Both yoga and Tai Chi, there's a risk of fall. And so we want to kind of mitigate that by the instruction we provide. We're also limited in techniques that require any sort of hand over hand assist, any tactile feedback, or any equipment that can't be accomplished remotely. So, these classes here that are kind of featured on this image are classes where the patients come into the clinic and are able to access yoga virtually. When patients are at home, we often teach classes where there's no mat or equipment involved. Sometimes we'll do chair yoga, so we assume most patients will have a chair within their home that they can do that with. There really has to be guidance to modify the environment and any sort of tasks that might have to be readily accessible. At UCLA, we have Julie Rowland, who's our certified yoga therapist, who's able to offer these same kind of therapeutic classes in yoga. October and November classes are free. They're from the 12 to 12:30 hour, and the information is provided there. But I think this is really a benefit of what we can do virtually, both mindfulness and yoga, really well established kind of complementary and integrative health modalities that can be delivered virtually. Now let's talk about acupressure. So, acupressure refers to the stimulation of points along meridians using manual pressure rather than needles. And there have been studies kind of evaluating acupressure versus acupuncture. And for the most part, when delivered properly, acupressure, you know, is effective for the treatment of chronic pain in patients compared to acupuncture. Certainly, acupuncture requires a skill set and education of the provider being able to provide that. Patients can perform acupressure on themselves or can be given to them by their caregivers. And there's a very minimal requirement of this technical knowledge. And I think that's the real benefit here. It's been shown to be beneficial in patients with chronic low back pain, osteoarthritis, and dysmenorrhea. And these are large clinical trials. And it's feasible and effective when taught via telemedicine. Um, One of the benefits we have here at the VA is that we have quite a few MD acupuncturists providing care, just as the same as we do here at UCLA. And as a result, we could easily kind of scale our acupressure visits. So we were able to kind of continue to provide acupressure for patients who couldn't come into the clinic during COVID. And that's been one of the kind of benefits of having that level of kind of telehealth engagement. Um, so for virtual acupuncture, so the benefit is continued integrative services for chronic pain, and it empowers the patients with more self-care tools, right? So this image is really showing, one is showing a caregiver providing the acupressure point. This is a patient providing that on themselves, and this is the provider kind of teaching this virtually. And so there's limited hands-on examination or physical touch therapy. So, the points selected are more basic and easily accessible. You might have to do any sort of modification of accessible points as needed. Um, During the visit, we describe the location of the point and then demonstrate how to locate it on ourselves. We choose points based on the patient's ability to access them. Most are on the legs, hands, arm, face, or head. And we recommend starting with gentle pressure or circular massage on the point and then slowly moving to more firm pressure. And what's nice is that, caregivers can be taught to assist here. And this is where I think there's going to be more emerging evidence. There is evidence that shows that acupressure is feasible when delivered via telemedicine, and it is effective in chronic pain. What I'd love to see, and I think where the research is being done right now, is on whether or not during COVID this has been scalable and clinically effective for pain management during this kind of critical time. Another area that's kind of emerging is hypnosis. So hypnosis, is another service that's considered kind of a level 1 service for pain, meaning that it is considered a service that is an integrative modality that is effective as a non-pharmacologic therapy for pain. And prior studies have shown that audio taped hypnosis or asynchronous delivery methods are more effective than no treatment at all, but they're certainly less effective than a live hypnotherapist. And hypnotherapy delivery via telehealth is a challenge, right? So it's really hard to get that level of engagement and hypnotic response via telehealth. But I think virtual reality here really is kind of a new innovation in where this is going. VR can actually enhance the hypnotic response in those with low hypnotizability, and but the problem is that this has been cost prohibitive for many. What we do know is that there has been a meta-analysis, so multiple studies. I think there was 8 studies included in this meta-analysis by Rousseau et al. And it really showed that VR, virtual reality-based hypnosis, provides both short-term significant decreases in pain intensity, pain unpleasantness, time spent thinking about pain, and opioid use. So I think as telehealth develops and virtual care access kind of increases, we're going to see the cost go down for these virtual reality based tools, and perhaps hypnosis, it will be kind of more evaluated for telehealth delivery. So I think this is kind of an interesting and emerging area. Certainly there's tons of kind of work being done on VR, just kind of in the integrative health space in general. um, Also want to talk about kind of another kind of emerging area, and this is kind of the biofeedback and remote patient monitoring. So these are areas where, so this is an example of an app that is a pilot study of patients with depression using a heart rate variability feedback biofeedback system. So a system that connects to their smartphone or tablet with a heart rate variability monitor, and the patients then are delivered kind of either a meditative practice um, asynchronously, and then partnered with digital health coaching. And so this is an industry sponsored study, and it was not randomized. So I'm not going to show the data here, but certainly reported an improvement in depressive symptoms. I think what's most kind of interesting about this is that this is really the future. This is where we're going. We're really going towards monitoring what's happening moment to moment when we deliver these integrative health modalities, and figuring out how to deliver them to a larger cohort of patients, either digitally or virtually. And so there's several of these industry sponsored studies on remote monitoring. Every day I look, I see a new one. I think some of the interesting ones are, a- Apple Watch based applications that can kind of uh, not only track sleep, but also help kind of improve sleep. There are vibrating devices that kind of give patients immediate feedback when their heart rate goes up, or they sense a change in their breathing. So again, we'll have to see where these actually play out when it comes to the data of effectiveness. I think when it comes to innovation, I think the sky is the limit here. I think this is where all of the innovation is really going. It's in these remote monitoring devices, coupled with telehealth, coupled with digital coaching, but we'll have to see. And when we talk about the future environment of telehealth and integrative medicine, I really want to, again, circle it back and bring it back to kind of where we started, because both integrative medicine and telemedicine are really centered around patient self-empowerment to improve health and prevent disease exacerbations. And in telemedicine, we accomplish that through increasing digital access and remote monitoring for patients to actually be able to communicate and connect with their physician, right? So, as an endocrinologist, I have patients who have Bluetooth connected glucometers, and I can kind of remotely review their data and couple that with either a telephone or a video visit. We have patients that use EKG tracers for chronic disease management if they have chronic heart disease and other challenges, and we know that these are effective. When it comes to integrative health, we know these same things in terms of, empowering the patient, taking a patient-centered approach, making sure that we're addressing their mind, body, spirit. I think it's really interesting to couple those aspects with digital monitoring. And I think the increased use of wearable and Bluetooth connected devices in clinical care will actually expand the delivery of telehealth-based complementary and integrative health. And then what's really interesting is that, the NCCIH put out a call for applications in May 2020, and that funding call kind of goes through 2023 on funding opportunities for telemedicine delivery of complementary integrative modalities. And that's really what's going to inform our future state. The NCCIH has made it a priority to study these mind-body practices incorporated into patient care and really focusing on pain, stress, anxiety, and other symptoms, as well as kind of healthy behaviors. And really finding ways to integrate that via telehealth, I think is the wave of the future. And then kind of lastly, and I want to close a little early because I really appreciate everyone giving me their lunch hour to talk here. Everyone right now is really struggling with kind of the enormity of everything we're facing with COVID. And I hear the terms trauma-informed and trauma-informed care thrown out a lot. Um, I think I want to show this slide from 2014, and this is really kind of the basis of our VA-based approach. I mean, we have a population with PTSD, chronic PTSD. I mean, we really understand trauma and stress, and we know how to do this. And we understand that we not only have to address individual and interpersonal needs, we need to have community-based solutions and kind of systems-based solutions. And it's not just about kind of getting to resilience and recovery. It's really about kind of creating that network and that environment. And I see telehealth as a way to bridge that divide and increase access and connection. So I'm really excited about all the advances in telehealth and integrative medicine. I think there's a lot we can accomplish in the future. I am open to take any questions. Thank you very much for your time. Dr. Huey, I don't think I can hear you.
No, outstanding presentation. Thank you very much for sharing, a very comprehensive, approach of using telemedicine to improve healthcare. I think that your idea about getting funding to help with patients going through COVID-19, I think would be a very important project, because there are going to be so many people who are the long haulers that are going to be like many of the people with the chronic fatigue syndrome of like the last 20, 30 years, that infectious disease are, having trouble because the focus has been on the pathogen and not on the host. And I think that, the integrative health approach focus on, repleting the system that has been dysregulated and depleted. Yeah. So I applaud you for not just sharing what you have done, but also pushing this forward. Thank you.
Thank you.
I had a quick question. In regards to the significant disparities and how rapid scaling aggravated those disparities, understanding that there's lots of socioeconomic issues, broadband access, obviously there's an interest in addressing those disparities. From a system perspective, how did the VA address that? Did you have like a telehealth team that was assigned that just worked on telehealth literacy with a group, or was it office by office that each office had to kind of figure it out themselves? Just to give us a sense of what we're looking at if we want to expand into that space.
Yeah, so we were actually fortunate here. So telehealth literacy had become a priority for the VA kind of early as we started scaling. So we were provided with guidance and a mandate to really create a team to really provide test calls for patients. So I have a team of 10 telehealth technicians that every day that they field consults from primary care, mental health, subspecialty care, so that they can reach out to the patient and hands-on provide them with that education on how to access telehealth. I mean, certainly we have some patients that are savvy and we can just kind of give them instructions, but really it does take that team in place. I think the other factor there is that we also have a program to loan digital devices. So when it comes to patients you don't have access to care, we can provide them with that care with loaner devices. So those two programs have really been integral in terms of being able to provide these services.
Thanks.
Yeah, many of us who are doing telemedicine, and I think the FPG data is about 80% office, 20% video right now. We all know that there are always technological issues, right? And I would say in my experience over the past 8 months, generally most visits work pretty well. I would say like 95%, but there always is that patient where the app crashes or, they whatever it may be. And, we typically just refer them to tech support and they usually reconcile the problem. The problem is that in their visit, they can't get that done within the 2-3 minutes that they have in order to not, squander the time of the visit.
Yeah, I think, trying to solve this for UCLA-based system, and I have the same problem when I'm at my UCLA clinic. And I think, having a clinical champion in each clinic, like a telehealth clinical champion, I think is going to be one option. I don't know the feasibility of that within the system, but I think that's, whether it's a patient care assistant or someone, I think that's going to be the way to go, because you kind of need that day of kind of care as well.
Yeah. And our backup plan is sending a Zoom link, right? But by the time you create the meeting and email the Zoom link and the patient signs on, you're already, halfway past your appointment.
Yeah, definitely.
But I've been surprised by how many of my elderly patients have been able to connect. They all FaceTime with their grandkids, so they all know how to connect by video. But they've been one of the savvier groups, which I've been pleasantly surprised by, because they're also the higher risk groups who should be staying at home and who are higher risk for COVID as well. So they, I think, have been a group that has really benefited from telemedicine during these past months.
Yeah, absolutely. And I think the CMS reimbursement has been critical for that population, and pushing forward legislation that keeps that parity, I think, is going to be key in terms of maintaining the sustainability of these programs.